the management of I'm telling what you can do. Once you have done the इसमें दिखा दो whatever I have discussed इसमें ज़्यादा कुछ है नहीं है ना so these are the 5 things that will come mostly trauma and chemical injury are the problem that we are going to face acute glaucoma you have to be aware of this why because they will present like a case of acute abdomen no. Just I think 2 days back one of our professors from biophysics she had severe headache and vomiting. So they were taking her for MRI. But somehow, I'm not going to take the name of that faculty, but the faculty's sister is my unit head. Okay. So they just call my unit head, Professor Namta Sharma. Something is wrong. We are taking her for that. Then she said, okay, if you have not left yet the campus, have a look in eye emergency. Should be a raised diagnosis. But actually, she had raised diagnosis. Okay, so the suspicion part is very important. If they wouldn't have called her, they would have gone for MRI. MRI में कुछ आता नहीं. Almost 24 would have been lost. By the time the eye would have been checked. So acute glaucoma presents like a case of acute abdomen. Acute glaucoma means acute angle closure glaucoma. Rest of the glaucoma will never come to emergency. Okay. So acute glaucoma is a thing that you should know. uveitis, I don't think uveitis patient will present to you. It's a low grade inflammation, so not going to present to general emergency. But acute glaucoma patient may present. All this vision loss, they will definitely go to some ophthalmologist. Giant cell arteritis and optic neuritis, they may present to you, but there will be associated problems like pili meningitis, vision loss, or patient is having severe headache, pulsatile headache, and then there is vision loss. So that will be taken care of. So for you, trauma, chemical injury, these are the two important things. So any trauma, mechanical globe injury can affect anything. So this is what I was discussing about. Injury can be two types: open globe, closed globe. Open globe is again classified into rupture, laceration. I'll explain this in the next slide. Okay, but remember there are two broad categories: open globe and closed globe. Open globe means something with sharp object like knife. Closed globe means with a lathi, very common, or a fist injury. So how to define that? So open globe injury means there is a full thickness wound of the eyeball. Cornea or sclera, there is a full thickness wound. Closed globe injury, there is no full thickness involvement of the eyeball. Again, this both these are classified into following. Remember this: rupture, laceration, contusion, lamellar laceration. So what is contusion? Contusion you all know, there is a edema, right? There is no full thickness wound, but there is a edema. Lamellar laceration, there is partial thickness entry, not a full thickness wound. So contusion, lamellar laceration are types of closed globe injury, where there is not a full thickness wound in the globe. Rupture and laceration, these are open globe injury, where there is a full thickness wound. Rupture means full thickness wound of the eyeball. Laceration means again full thickness of the eyeball, but laceration is caused by a sharp object like knife. Rupture means there is blood trauma, but the pressure is so much that the eye burst. Okay, and that's why there is a full thickness wound. Okay, classification clear है? Open globe, full thickness wound. Closed globe, no full thickness wound. Open globe, rupture, laceration. Rupture is because of some blunt object trauma. Laceration is because of sharp object. Contusion, lamellar laceration type of closed globe and partial thickness wounds. Okay. Any laceration where some sharp object has entered into the eye can have three types of injury. One is penetrating. Penetrating means if you remember your MBS knowledge, only there is an entry point, no exit point. It has not got the other part of the globe. Intraocular foreign body, something has entered and something is with that, some foreign body is there inside here. Okay, the last part is your perforation. In perforation, there is blood, both entry as well as the exitome. Something has entered the cornea, exited from the sclera, and now in the orbit. Okay, orbital apex. And even I have operated one patient where the patient was driving some two-wheeler and truck loaded with the iron rods were there. Iron rod that penetrated the eye, then it had reached almost to the optic nerve. So those are example of your perforation. So as the name suggests, closed globe injury they carry good prognosis because your eye wall is not open at all. Open globe again perforation carries poor prognosis. Penetrating if you manage it timely, then that will be good prognosis. Intraocular foreign body depends on the type of foreign. If it is a vegetative matter, then that will induce severe tissue reaction, right? That will lead to a lot of trauma. But sharp objects like iron piece, they won't do any much reaction in the immediate period. But if you leave them for a very prolonged period of time, 5 or 10 years, then that can also damage the photoreceptor. Okay. So this classification is important. At least when you are sitting in emergency, if a patient comes to you, should be able to at least make this diagnosis. Open globe injury, rupture. Closed globe injury, corneal laceration. Okay. I hope these terms are clear to you. So this is the current classification that we use. It's called Birmingham eye trauma terminology, or we what is the BET? BET, BET terminology. Okay. So this is what the second thing I was telling you about. What all things you should note. See, in an open globe injury, there are three zones, right? In zone one, cornea and limbus. That is zone one. Zone two, from limbus to 5 mm into the sclera. And zone 3, beyond 5 mm. These are the three zones. You can write open globe injury, zone 1. So that will suggest that it is cornea and limbus. Okay. Type, I have already explained. Okay, so you can write open globe injury, penetrating trauma, zone 1. Then the person will be clear, okay, open globe injury hai, penetrating means there is a entry point which is restricted to cornea and limbus. So this is the classification that we use. People, I just told you, it's important for you to check for pupillary reaction. If there is massive trauma, everything is coming out, then it's practically impossible. But if there is a single laceration, single penetrating injury, you should check it. If it is negative, as I was telling you, that suggests your optic nerve is there. Optic nerve, till the time your optic nerve is intact, no matter how severe the injury is, your pupil will react. Okay. So these people you have to note. Visual acuity, I don't think this chart will be there in emergency. This is the ETDRS chart. With the notation like 20, 40, everything. But you can record on spectrum also. Sorry, in Snellen's acuity. Snellen's acuity, the denominator is it's like 6 by 6, 6 by 60, right? So this 20 will always be 6. So you can, for example, if somebody is writing 20 by 40, you can extrapolate that to how much? 6 by 12, right? So Snellen's 6 by 12 is equal to 20 by 40. Scientifically it's not correct, but this is the rough estimate that we make. Okay. NLP means no perception of it. Okay. So when a patient of ocular trauma is with you, you have to mention all these things. Okay. Open globe injury, rupture type, zone 3 with APD. Vision perception of light. So this completes the wet terminology. Right? So that was for open globe. Closed globe, the zone which I was telling you. It's external means it is limited to bulbar conjunctiva, sclera, and cornea. Only the outer coat is damaged. Zone 2 means entry segment structure is also involved. Entry segment means lens, ciliary body, everything. Posterior segment beyond the lens. Okay. So any trauma, closed globe injury, I told you, with the trauma, following the trauma, there won't be any full thickness wound. So there is a partial thickness wound which is restricted to cornea, conjunctiva, sclera. Rest of the structures are fine. So that is your zone 1. Zone 2 means there is a partial thickness wound, for example, iridodialysis is there, or your lens subluxation is there. Okay. So your entry segment structures have been damaged. Then that becomes your zone 2. Okay. Zone 3 means posterior segment, retinal detachment is there, Optic nerve head avulsion is there, so that is zone. Rest of the things are same. These terminology I have already told you. What is continuous, what is lambda laceration, what is superficial foreign body, what is mixed. So this is how we classify the system. If you see this image, yellow part, sclera, limbus, cornea is involved. Then that is your zone 1. Red, enter segment, anything entry to iris or posterior pole of the lens. Zone 2, zone 3 means anything beyond your posterior capsule. That is zone. So this terminology is important and this you should be able to make in your emergency, right? Rest of the things I am not going to discuss because it's not required for you, but just to show you few pictures, right? As I was telling you, zone 1 is involvement of conjunctiva, sclera, cornea. You see, here is an example of conjunctival laceration. Can you see this? So this is the conjunctival laceration. This is zone 1. This is subconjunctival hemorrhage with superficial foreign body. Okay, again zone 1. This is conjunctival chemosis. So all these are examples of zone 1 open globe injuries. Corneal injuries. Corneal injury, there will be corneal laceration. I don't know why this picture is not. So you can see there is a linear laceration wound in the cornea. You can see on the top left arm. The cornea is a, for you people, convex is okay. Convex appearance is there, it is transparent. Whenever there is any laceration or perforation, if there is only laceration, you will see cornea is edematous. The linear mark is quite clearly visible. If there is a perforation, then you will see the chamber is completely flat. The iris may be popping out of the corneal laceration. Okay. Interchamber, I was telling you, this is again a zone 1 injury. So interchamber, the most common finding that we get is hyphema. See, this is the blood has collected here, hyphema. So whenever you see such a case, like hyphema is there on top, this you can see on top right also. Hyphema needs to be drained immediately if the intraocular pressure is beyond 40, or if it is there since 48 hours. So whenever you see such a patient in your OPD, I have seen several times what people do, they write chimeral fault and ask the patient to come up on test visit. Don't do this, you have to send the patient to any eye surgeon because the patient needs immediate drainage of that hyphema. So this 7, and this is basically a question to MD student in the exam. 7 ringers whenever there is blood trauma. So see, eye is structure like this, So most of the structures are attached in a circular fashion. So they get detached from the root or they become weak. That is what is classically described as 7 ringers form. Okay. You can remember because this is the mnemonic. So the first is iris tear. The iris is, you can see, if this is the iris, there are radial sphincter tears in the iris. Okay. Second is iridodialysis. This is the root of the iris. The iris is separated from the iris fluid. Typically, parcel में तुमने पढ़ा होगा जैसे D-shaped pupil. जहाँ पे तुम्हारा pupil root shape होगा, that will become like this. Rest of the pupil will be like this. So that is a classical D-shaped pupil. 3 is anterior ciliary body recession. So normally this is the cornea, this is the iris, and here the ciliary body lies. Okay. So ciliary body angle recession. That is the third type. It's not possible to diagnose this on slit lamp by you people. This is gonioscopy. So some experts can only make this diagnosis. Then cyclodialysis, like iris gets detached from the root. Similarly, your ciliary body may get detached from the left, which is known as cyclodialysis. Trabecular meswork TMTR. This is the trabecular meswork, where your aqueous drainage occurs. So there could be a tear here also, right? Jonular dialysis. Jonular dialysis means this is the lens that is attached to the ciliary body by jonules. If this jonules gets broken, then there will be lens or jonular dialysis. Last one is the retinal dialysis. See here, retina is attached to the ciliary body here. If the retina gets separated, then that is known as retinal dialysis. All these are possible complications of any blunt trauma. I'll just tell you one incident. We had a sir named Chilmadis. He was playing in the gymkhana. The shuttercock hit his right eye. Cross examination, everything was fine. He was playing, then after did an indirect ophthalmoscopy, we see that there is a retinal dialysis. Okay. So retinal dialysis initially it will be completely asymptomatic. पता भी नहीं चलेगा vision कुछ affect नहीं होगा. Over a period of time, the retina will get detached. See, this is out of your visual axis, right? Light comes like this. This part is out of your visual axis. So तुम्हें vision affect होगा ही नहीं शुरू में. When the retinal detachment involves macula, then the vision goes. Okay. These are the 7 rings of trauma. Somebody please close this door if it is not absent. These are the 7 big signs of ocular trauma that you should remember. Depends. At times people remain like this for 2 years, 3 years, and accidentally get a time. But if it is severe, almost 360 detachment is there. Within 1 month, the detachment is there. So these rings you remember. Why you remember? Because at least you should have an idea. If somebody is hit with a fist, it doesn't mean that only eye red or antibiotics. All these things may be there. So whenever you are dealing with a blunt ocular trauma, even if the eye appears white, you have to refer the patient to an ophthalmologist for posterior segment screening. This dialysis identifier, this is the most dreaded one. Rest of the things we can manage. But this, if retinal dialysis is there, then you have to dilate the pupil and you have to do an indirect ophthalmoscopy with indentation. So which a retina trained person only can do. I cannot do. Example else. Okay. Any blunt trauma, ophthalmic consult is a must for retinal screening. Okay. Iris, this is what I was telling you. This is a corneal laceration. See, उसमें ये picture आ नहीं रहा था. When you see there is a linear corneal laceration with iris being stuck into that. Okay. This is again a limbal, corneal and scleral perforation with iris pull up through that. Okay. So these are different examples. If you see such cases, it's not just beyond your control. You cannot manage such cases. But at least you start an antibiotic. Whenever there is perforation, please start with oral antibiotic. Okay. Oral antibiotic is a must. Start with an oral antibiotic and topical antibiotic eye drop and cycloplegic. These 3 you must start. Steroid, usually you should avoid. Why? Because any blunt trauma, any trauma can be associated with fungal infection. If you give steroid on the immediately after the trauma, you may be putting the patient at risk of fungal infection subsequently. Antibiotic, commonly we give moxifloxacin or gatifloxacin. You can simply write that moxifloxacin is 0.5%, gatifloxacin is 0.3%. Cycloplegic, you must be knowing homatropine, bromide 2%, or atropine. Atropine usually we don't give because that is very long-lasting effect. So you give homatropine 4 times in a day. Okay. So gatifloxacin 6 times, homatropine 4 times, okay, and an oral antibiotic. And give some painkiller. Patient must be having pain, right? So preparation like serotonin. Topical. Topical analgesics are not that useful in such cases, and also topical NSAIDs they interfere with corneal healing, and there have been reports of corneal melting following use of NSAIDs in eye. Topical NSAIDs. So don't give topical NSAIDs at all. In fact, at RPC we don't use topical NSAID at all, except in cases of uveitis, okay, where we don't want to give steroid for a long time. Any corneal injury, you must be noting. You must have noted your friends using for conjunctivitis, ketorolac, all this NSAID formulation. You should advise them not to use them. NSAID are not good for your cornea. So any lens trauma, the jugular dialysis I had told you, no? So it's jugular. So this is the normal lens, no? It's exactly in the pupillary plane. But see this image, no? The lens is this has sunken down. Okay. This at times may be visible with your torchlight examination also. But slit lamp it will be very clear. If there is subluxation, it's very hard for you people to miss unless your focus is somewhere else. Okay. So this is an example of jugular dialysis for the lens subluxation. All these cases need to be referred. Glaucoma, I told you, glaucoma, the only one scenario where acute cases will come to this emergency is when it is associated with headache, vomiting. So any patient comes to you, in fact, the diagnosis of angle closure glaucoma initially it was described as acute abdomen by the first author who described this. He reported around 7 cases of acute abdomen. Later on, it was found that the main culprit was raised IOP, not acute abdomen. Even there were instances in past, maybe 100 years back, where people have been taken to OR for laparotomy to see what is wrong. But the problem is in the eye. Okay. The patient will come, patient will say कि एकदम से vomiting हो रहा है, headache भी हो रहा है. Primary complaint ocular होगा ही नहीं. When you ask a lead question, what about the vision? Then they will say कि रोशनी भी down है. Most of the attacks are unilateral. Because the other eye vision is good, even the patient is not aware my vision is good. Okay, so this you must be aware of. Okay. Yes, I will be like exactly like your conjunctivitis. There will be ciliary congestion. There will cornea will be edematous. Just taking a picture of that. You can see the image will be exactly like this. There will be ciliary congestion. The cornea will be edematous. There will be severe pain. Okay. This hypopion won't be there, this white part, but rest of the picture will be exactly like this. You should know how to differentiate between a ciliary congestion and a conjunctival congestion, which are there in your MMS book, if you remember. See, this is a classical ciliary congestion. Can you see this? The congestion is primarily around the limbus. The fornices are free. Okay, so vessels will be running perpendicular to the limbus. If this is my limbus, my congestion will be like this. Okay, so that is a classical ciliary injection. In diffuse conjunctival congestion, in this patient, it's a mixed one. Can you see the congestion here? It's like a branching tree pattern. They are not perpendicular to limbus. The vessels will be going here and there, like branching tree pattern. Okay. So uveitis both can be done, but whenever you find very ciliary congestion in any of your eyes, you should refer the patient immediately. Why? Ciliary congestion suggests there is deep-seated inflammation in the eye. It's classically seen in severe uveitis or angle closure glaucoma. If it is a simple conjunctivitis viral, then you won't get the ciliary congestion. It will be diffuse congestion, more marked in the cornices. Cornices पता आता है ना कि evert करके देखो तो यहाँ दिखता है, ठीक है? So glaucoma, acute congestive glaucoma is there in your emergency. Winter summer, all this thing you cannot diagnose, so it's no point of discussing that. So the second most common following mechanical trauma, the cases that we see here is this chemical injury. Okay, the picture will be exactly like that. If you put a torch, you will see the cornea is red, white, conjunctivitis body, and a lot of blanching will be there. Okay. Most common culprit is holy. हो सकता है तुम में से कुछ लोगों को हुआ भी हो. Second is vitrolage. We have been a refer center, you may be getting those cases. But at times what happens, the problem is your focus is entirely on the face, neck, all these areas. So they contribute almost 18% iris, right? What is that rule? To burn the classification of the wireless rule of 9. So most of the time what we note, that first you start first aid, you do all this thing, and then you send the patient next day to the eye. You open the eye is like this. Okay, but remember, skin trauma, all these things, even if you delay by 1 or 2 hours, it's not going to cause much harm. But you ignore the ocular injury, the vision prognosis is miserable if you delay the treatment. Okay. So holy injury, thermochemical injury, these are the common type. Most common is holy injury. Management I have already told. Being a resident in emergency, your first job is to clean the irrigation eye. Okay. This is the PS paper. Even you can purchase and keep it with you. Not very costly. Or you can ask any of your medicine representative. They can give you this. Okay. These are color. You just place there will be a strip. You bend it here and put it in the lower eyelid. Pull it like this and touch it here. Based on the color that is matching, that is the pH of your eye. So first check the pH. Okay. And then just open the eye. If you know the slit lamp, you can see through the slit lamp. If you see any source of chemical is still there. For example, tuna particle is a very common injury here. Why? Because edible tuna देखा है कोई पान खाते हो तुम लोग? मीठा पान तो खाते होगे ग्रीन पान भी खाते हो आफ्टर ए ट्रिप देखा है? So they have this edible tuna which is in small polythene packet, white design. That is packed. So when you pack it is okay. But if you keep that for a long time, in India में practice होता है ना लोग घर पे रखते हैं पान का box. So they keep it there. If suppose it is there for a long time, then this calcium hydroxide due to natural reaction they produce carbon dioxide. So the pressure within that packet is very high. If somebody kids or mostly we get this type of injury in kids only. Doing while playing in the press set, then because the pressure is too high, it bursts, and the tuna flies with a very high speed. Okay, or else somebody is not going to see. This is the tuna. This is the edible tuna. Could you believe this? This edible tuna is in the corneal stroma. So the moment they compress it, it bursts, and it moves so fast it can get into cornea. Okay, so this was a tuna plaque I had to remove. So this is very common in India. So if you see any such whitish material is there, which has not penetrated but still lying on the conjunctiva, simply take a plain forceps, put some topical anesthetic drops like paracaine and remove it. If you leave it, it is going to cause more and more damage. Okay, so do a gross examination, remove any source of potential injury. After that, do a irrigation for 30 minutes. Acid injury, alkaline, it doesn't matter. Use ringer lactate, if not normal saline. If that is also not there, कोई बिस्लरी का बॉटल मांगे उससे भी तुम क्लीन ठीक है that is your first management system. Second, as in mechanical trauma, start an antibiotic, start a cycloplegic. That is the minimum that you can do. Okay. If you did too much theory or your concept in ophthalmology is little bit clear, so you can add oral vitamin C. Why? Because vitamin C it helps in collagen synthesis and it helps. So we normally give vitamin C 500 milligram 4 times a day. Also we give doxycycline. Why? Because in chemical injuries, the mode of the mechanism behind corneal damage is matrix metalloproteinases. Now it has been proven that doxycycline inhibits this MMPs. So that will inhibit your corneal lysis or stromal lysis. Stromal melting will be prevented. So normally we give vitamin C. If you are confident enough about your diagnosis, you can have doxycycline. Okay. Topically, antibiotic, cycloplegic. Steroid is a must. But for that you will have to be sure. And then infection लेके आया है तो chemical injury सोच के steroid दे. If you are 100% sure कि holy color ही गिरा है, then don't hesitate. Start steroid. Steroid is prednisolone acetate 4 times a day or prednisolone phosphate 4 times a day. Normal strength is 1%. Low strength is also available, but in chemical injury you have to give high strength. So antibiotic, cycloplegic, steroid are a must for any chemical injury. If you start steroid immediately, the prognosis improves significantly. But there is a catch here. You all know steroid is a double-edged sword. Okay. It will inhibit inflammation. It will inhibit healing also. If you keep it for a long time, it will control inflammation. But inflammation again is a double-edged sword. Some inflammation is required for healing. Because too much inflammation is dangerous to the eye because that will not melting. So steroid normally if you take chemical injuries within last 10 days, we give steroid. Any injury beyond 10 days, if the patient has trauma 1 week back or 2 week back, then don't start steroid on your own before the ophthalmologist. Okay. Why? Because the phase after 10 days is your healing phase following any chemical injury. So if you give steroid during that period, healing is harmful. Okay. So steroid, antibiotic, cycloplegic. Lubricant, as you can see here, a lot of defect, है ना, conjunctival defect है ये. So you can add one lubricating eye drop. Most common lubricating eye drop is CLC 0.5%. Okay, carboxymethyl. Classification system at your level is not required. But remember these two terms, if somebody asks what classification system is used, this DUAS classification system is currently used for chemical engineering. क्या तुम्हारी ये है तुम उसको एडवाइस कर रहे हो लिखे जा रही है नोट okay pathogenesis one point to remember if there is a acid injury it's a good thing for the eye good matlab relatively less bad compared to alkali why because acid has a property of coagulating the protein one is collagen so collagen are coagulated so no further acid can penetrate into the deeper layer may come as a MCQ. Alkali injury is dangerous. Why? Because they saponify the cell membrane. So the moment the cell membrane is saponified, the alkali penetrates much deeper. That's why alkali injury is more dangerous. Second, because acid coagulates the protein, so the coagulation will happen in cornea as well as sclera. So the moment scleral protein gets coagulated, sclera will become stiff. If the sclera becomes stiff, what will happen? ऐसा था तो इसको ऐसे कर दो तो क्या होगा pressure inside the eye will go up है ना so in acid injury it's better to start one anti-glaucoma medication also ठीक है anti-glaucoma क्या देते हैं normally तो तुम hypertension में देते हो timolol 0.5% okay so this is the primary management that you should be able to do in this emergency after that you refer the patient to RPC okay any doubt so these are the two emergencies that you have to manage here okay. I think this is it all this scenario just few words suppose somebody comes to you which is a hypertensive patient or any patient with some coagulopathy predisposition like valvular heart disease and the complaint is my vision is completely gone then think of the CRO okay CRO is a disorder where if you don't treat immediately the optic nerve goes into atrophy immediately the patient will be blind for the whole life okay so any patient of hypertension valvular heart disease atherosclerosis coagulopathy pancreatitis उसमें भी होता है ना chronic liver disease if the patient complains कि मेरा ना सुबह से दिख ही नहीं रहा है कुछ भी क्लासिक कंप्लेन ये कि एक ना ब्लैक पैटर्न से आ गया आपके सामने डोंट इग्नोर वी हैव अ टेंडेंसी कि ठीक है दैट इज देयर emergency you are surrounded with 10 people somebody saying this somebody saying that है ना so you are a bit irritated frustrated at times है ना so don't ignore this complaint if this complaint is there immediately send the patient to emergency and this is vice versa you are sitting in opthal emergency आगे कभी जाके emergency लोगे और आपको दिख गया कि CRO का पेशेंट आया CRO का पेशेंट है क्लासिकल होता है नो पीआई विजन कम हुआ कुछ नहीं बोला मतलब कुछ दिख ही नहीं रहा है ना क्योंकि आपका ऑप्टिक नर्व का वास्कुलराइजेशन ही बंद हो गया ना ब्लड सप्लाई उसमें कुछ नहीं दिखेगा नो परसेप्शन ऑफ लाइट द मोमेंट यू सी नो परसेप्शन लाइट दिस शुड बी योर फर्स्ट डिफरेंशियल डायग्नोसिस अगर कोई नो परसेप्शन लेट लेके आया है डू ए फंडोस्कोपी यू विल सी अ पेल डिस्क एंड दिस क्लासिकल CRO का पिक्चर है यू विल गेट दिस चेरी रेड स्पॉट क्या होगा उसमें एडजेसेंट रेटिना व्हाइट होगा तो मैकुलर वाला पार्ट रेड होगा दैट इज चेरी रेड स्पॉट फंडोस्कोपी नहीं भी है you suspect this then you should send the patient emergency to cardiology department why because there has to be something na, that is blocking your central retinal artery so this emboli it might have come from the heart है ना and वो आएगा कैसे central artery so ophthalmic division only है ना so internal carotid then ophthalmic division then central retinal artery that means there could be more emboli which are moving and if you don't treat them immediately or don't do any emergency maneuver then they may cause a stroke so any patient of CRO if diagnosed in ocular emergency we send them directly to cardiology to rule out any coagulopathy the same any patient with vasculopathy or coagulopathy developing sudden loss of vision we have to refer them immediate management क्या होता है since the emboli may be lost somewhere we do ocular massage if you vigorously do ocular massage there is a chance that this emboli may get into distant artery and then get absorbed. कहीं पे जो क्लॉक करके हुआ होगा, if you jerky movement, इतना बड़ा एम्बोलाई था, 3-4 पार्ट होके इसमें disappear धीरे से, है ना? That is what happens. If that is not there, when what we do a paracentesis. आई का प्रेशर को हम सडनली कम कर देते हैं. That is also helps in dislodging the emboli, है ना? Your goal is कि जो central retinal artery को block कर रहा है, that should get mobilized from there and go into peripheral arcades. जैसे यहाँ पे vessels है ना, इसे ऐसे कोई छोटे-छोटे arcade में जाके चला जाए. That won't cause any problem. So either you do ocular massage or do a paracentesis to lower the intraocular pressure. I think these are the 4 group of emergencies that you should be aware of, and you should be able to refer after starting the first aid management. Okay? कोई doubt इसमें तुम्हें अभी? Speak louder. तुम बताओ, what is the golden period of nerve injury? Any other opinion? 6 are na. So all these traumas where there is a risk of injury to the optic nerve has to be done within 6 hours. If this is done, then the chances of injury goes further down. Slit lamp, देखो slit lamp is more like a practical thing. मैं तुम्हें main part बता दूंगा. People practice. If you struggle, then you can visit to our emergency once, and I'll ask one of my staff to demonstrate you how to operate, है ना? वहाँ पे कोई जाओ, मैं जो part दिखाऊंगा, you just keep on telling me those things. Huh? Somebody please sit there. तो slit lamp ये history तुम्हें जरूरत नहीं है. These are all for ophthalmology resident. So these are 3 basic systems, है ना? This is your observation system. See, yes, that is those are your 2 eyepiece. This is your mechanical system where the patient is positioned. Okay. Then there is the illumination system. That part जो तुम move कर सकते हो. These are the 3 part you should be aware of. Okay. This is the observation system. Detailed theory is not required for you, but if you want to read, these are simply plano convex lenses are there. Plus 10 diopter का lenses होता है, 10 to 5 stereosis, but all these things are not required. तो exam में कोई नहीं पूछेगा. ये बस remember these are the 3 system. In that system, see whatever he is pointing, this knob will be there. See the numbers, okay? This is 6x. मतलब the image will be magnified 6 times. 10 means image will be magnified 10 times. Okay? So that is the rotating drum. क्या क्या है इसमें देखो? Yes. Okay, the same one is here. है ना? कुछ slit lamp पे बस 2-4 ऑप्शन होते हैं, 1.4 कुछ. But this is the advanced where you can magnify 40x. Okay, you can just rotate this drum and the magnification changes. But remember, whenever you are doing any slit-lamp examination, always start with 10x. Then increase the magnitude. First 10x में focus करो, then you increase the magnitude. सीधा 40 पे लोगे तो तुम्हारा focus चलेगा. ठीक है? This is again the same thing. अच्छा यहाँ पे देखो. Could you see the marks here? है ना? वहाँ पे देखना, this should be always on 0. यहाँ पे पावर होता है -5, -10, है ना? So this should always be, there is a mark here, this linear line. So 0 should coincide with that. That means your lenses doesn't have any power. अगर एक में तुम 0 रख के दूसरे में 10 लग के करोगे तो तुम्हें बाइनोकुलरिटी नहीं दिखेगी. पीपल की क्लास के बाद आराम से देख लेना है. Illumination system, you need not to go for the details क्या lamp होता है, but somebody may ask you halogen lamp होता है. If it is a white light है ना, halogen lamp. आजकल LED लाइट्स भी होते हैं, ठीक है? तो इसमें मेन क्या क्या पार्ट होता है देखो. You have to be aware of this filters which you can change. Then there is a knob here, देखो, है ना ये knob. Yes, you can rotate that, है ना? उससे क्या होता है, सिस्टम ऑन करो, तुम लोग सारे उधर बैठ जाते हैं, दिखेगा ना क्या हो रहा है. देखो ये चेंज करने से you will get a clue here. यहाँ पे देखो कुछ एक साइज आ रहा होगा, है ना? नंबर आ रहा है ना? So this is the width of the slit. You can add 1, 2. इसमें होगा तुम्हारा till 8 होगा आई थिंक। अबे यहाँ पे देखो, ये देखो 14 तक है। एडवांस वाला कितना बड़ा अल्सर है ना, तो यू कैन मेजर विद दिस कैलिपर, है ना। मोस्ट ऑफ द स्लिट नंबर 8, बट थैंक यू तो तुम्हारे एसओडी सर को थैंक यू, वेरी एडवांस स्लिट नंबर, ठीक है। So this is you adjust the height of the slate, then there will be a knob somewhere here, देखो है नीचे एक knob होगा, देखो उसके ऊपर, अच्छा ये वाला, yes, this is the knob to adjust the width, है ना। देखो वहाँ आ रहा है, देखो इसमें तुम्हारा इल्यूमिनेशन बढ़ेगा, width बढ़ेगा, इसमें तुम्हारा क्लिप का साइज चेंज होगा, फेस पे डाले जा रहा है ये भी। यहाँ पे कोई पेपर वेपर कुछ रखो ना, तो तुम्हारे लिए ये नोब इम्पोर्टेंट है, ये इम्पोर्टेंट है, इसमें तुम हाइट एडजस्ट कर सकते हो, इसमें तुम विड्थ एडजस्ट कर सकते हो, ठीक है। दिस इज अ मिरर, जैसे तो तुम्हारा रिफ्लेक्टिंग मिरर है जो तुम्हें दिख रहा है, देन देयर इज अ रेड लाइट कमिंग, व्हाट इज दिस, दिस फिक्सेस इन टारगेट। इंडियन पीपल समझ ही नहीं आता ना कहाँ देखें, तो इधर लाइट को ही देखे जा रहा होगा ऐसे ऐसे घूम के ना, तुम्हें कुछ नहीं दिखेगा। पर इस प्रॉपर स्लिट लाइन एग्जामिनेशन पेशेंट हैज टू लुक स्ट्रेट एंड लाइट हैज टू बी फोकस्ड लाइक दिस। अगर पेशेंट तुम्हारा लाइट को ही फॉलो कर रहा है तो वो कभी भी तुम्हें कुछ नहीं दिखेगा ना। तो आज द पेशेंट की बाबा ये रेड लाइट पे देखो, उसमें देखो कुछ पावर वावर भी होगा, कुछ है दिख रहा है, ठीक है। तो ये देखो ये तुम्हारा फिल्टर है ना, फिल्टर चेंज करो, इनके डिफरेंट डिफरेंट कलर है ना, दिस इज ब्लू, कोबाल्ट ब्लू, अच्छा देयर आर डिफरेंट फिल्टर, जैसे इसमें भी तुम्हें दिख रहा है ना, ग्रीन फिल्टर, ब्लू फिल्टर, और एक होगा देखो, एक सर्कल होगा जिसमें बीच में गैप होगा, एक सर्कल होगा जो पूरा सॉलिड होगा, ठीक है। इमेज में देखो ना, जो सर्कल है ना यहाँ पे देखो, है ना, तो सॉलिड सर्कल में बहुत ज्यादा लाइट जाएगी, तो सपोज somebody is having problem with light, you can choose this hollow circle, उसमें तुम्हारा थोड़ा अमाउंट ऑफ लाइट जो जा रहा है वो कम हो जाएगा, ठीक है, ठीक है। ये तो मैंने बता दिया तुम्हें, ये मिरर होता है, ठीक है। तो फिल्टर है ना तीन, कोबाल्ट ब्लू, रेड फ्री, न्यूट्रल डेंसिटी। So this is your cobalt blue, this is your green one is red free, है red free इसमें, कलर, इधर और एग्जांपल ऑफ फिल्टर, ब्लू है, कोबाल्ट ब्लू है, रेड फ्री है, ऑरेंज भी है, येलो भी है, इधर और कलर डिफरेंट है। रेड फ्री, this is कोबाल्ट ब्लू, कोबाल्ट ब्लू is good for accessibility for skin, red free is for your blood vessel, this color is used by retinal people, इसका ऑपरेटिव है, ये पूरा कॉम्प्लेक्स है, नहीं आया? चलो ठीक है, रेड फ्री इज फॉर फंडस एग्जामिनेशन, आई टोल्ड यू फॉर ब्लड वेसल, कोबाल्ट ब्लू इज फॉर एक्सेल डिफेक्ट, न्यूट्रल डेंसिटी फॉर फोटोफोबिक पेशेंट, इसमें पेशेंट को लाइट से दिक्कत हो रहा है, ठीक है। तो ये एक तुम्हारा जस्ट एग्जांपल है ना, फ्लोरेसेंट डाई स्टेन किया हुआ है, जैसे केस ऑफ कॉर्नियल फिस्टुला है ना, सी हाउ द डाई इज गेटिंग डाइल्यूटेड हियर ग्रेजुअली, है ना। दिस यू कैन आइडेंटिफाई विद योर कोबाल्ट ब्लू पेन। इसके लिए सोडियम फ्लोरेसेंस स्ट्रिप्स होते हैं, यू कैन परचेज और यू कैन गेट इट फ्रॉम आरपीसी कैजुअलिटीज विजडम से धीरे से निकाल कर ले आओ, आपको देंगे। दिस पार्ट ये जॉयस्टिक दिखाओ, दिस इज टू पुश इट टू एंड फ्रो, है ना, दैट इज द जॉयस्टिक, है ना। पेशेंट सपोर्ट दो चीजें होती है ना, एक तो चिन रेस्ट, दैट इज योर चिन रेस्ट, देन देयर इज अ हेड रेस्ट, ठीक है, वहां पे हेड रेस्ट रहेगा तुम्हारा। फिक्सेशन टारगेट इज दैट रेड वन, दैट इज योर फिक्सेशन टारगेट। मैकेनिकल कपलिंग ये सारे जो कपल्ड है, दैट इज योर मैकेनिकल कपलिंग। देन 10 बस में आर्म रेस्ट, हाथ रखने के लिए नहीं है इसमें, ये है, ठीक है, नॉर्मली ऐसे बार होता है। ये जॉयस्टिक है, ये तुम्हारा पूरा सिस्टम है मैकेनिकल कपलिंग, ये तुम्हारा फिक्सेशन टारगेट है, ये तुम्हारा मैकेनिकल कपलिंग के साथ, ये तुम्हारा हो गया। दिस इज योर फॉरहेड एडजस्टमेंट, दिस इज योर चिन रेस्ट, ठीक है। कैंथल अलाइनमेंट यहाँ पे हम देखते हैं, इज नॉट रिक्वायर्ड बट यू कैन सी हियर, है ना। ये चिन रेस्ट में एडजस्टमेंट नॉब है तुम्हारा, इसको तुम ऊपर नीचे कर सकते हो, दैट इज द एडजस्टमेंट नॉब। पेशेंट्स हैंड ग्रिप, नॉर्मली जो बोल रहे थे ना साइड में होता है हैंड ग्रिप, इसमें तुम्हारा स्ट्रेट है। ये तुम्हारा फिक्सेशन टारगेट है रेड वन, जॉयस्टिक तो है ही। लो फिक्सेशन, लो फ्रिक्शन प्लेट, नीचे जो प्लेट होता है लो फ्रिक्शन प्लेट, जो तुम्हें चाहिए वो बता दो। दिस इज हाउ यू एग्जामिन द पेशेंट, ना देखो रेड लाइट यहाँ पे है, आस्क द पेशेंट टू लुक इनटू दिस फिक्सेशन टारगेट एंड डू योर एग्जामिनेशन, और द पेशेंट विल कीप ऑन फॉलोइंग यू। इसमें एक इंपॉर्टेंट पॉइंट देखो, एडजस्ट योर आईपीडी, तो लेंस है ना, यू कैन एडजस्ट इट लाइक दिस, है ना। तो किसी का आईपीडी 65 होता है, किसी का 56 होता है, but IPD is not properly set, it will not get a binocular, बस डेप्थ नहीं पता, तो कैसे पता चलेगा तुम्हारा कितना है IPD? एक आई बंद करके देखो, दूसरी आई बंद करके देखो, अगर तुम्हारा कुछ भी चेंज नहीं हो रहा है मतलब तुम यूनिओकुलरली देखो, ठीक है। तो उसके बाद में तुम्हें पता नहीं चल रहा तो आरपी सेंटर में एक साइन अप टू फोन जाके बोलोगे मुझे मेरा आईपीडी पता है, तो बता देगा, देन यू लाइफ विल बी माइक्रोसॉफ्ट वेट ओपन भी देखो, दैट इज योर फिक्स टाइम, बस फील होगा, लिखा है आईपीडी देखो, दिमाग है। जब तुम्हें डेप्थ व्यू दिखेगा ना, दैट इज योर स्टीरियोस्कोप। हाँ, नॉर्मली सेमी डार्क रूम में करते हैं, पूरी ब्राइट लाइट में करोगे तो तुम्हें कुछ अप्रिशिएट नहीं होगा। दिस आई हैव ऑलरेडी टोल्ड, स्टार्ट विद द लो मैग्निफिकेशन देन इंक्रीज। डिफरेंट इल्यूमिनेशन होता है, नो नीड टू रिमेंबर ऑल दिस थिंग, यू रिमेंबर व्हाट इज अ डिफ्यूज इल्यूमिनेशन, व्हाट इज अ डायरेक्ट एंड व्हाट इज अ इनडायरेक्ट और स्लिट इल्यूमिनेशन। ना डिफ्यूज मींस पूरा डिफ्यूज बीम होगा, जो पूरा सर्कल होता है ना, इससे एडजस्ट, हाँ, ये जो नॉब है ना, इसको तुम पूरा सर्कल करो, and see the diffusion. ये तो diffuse करना चाहिए, but like no flow. Straight. So direct diffuse illumination is the broad beam. Focal examination is the slit beam. Diffuse में you see the eyelid. Normally eyelid miss कर जाते हैं. See the eyelid, see the eyelashes, see the conjunctiva, see the cornea. Okay. Then you go for. So these are the example. Diffuse में तुम्हें क्या क्या दिख रहा है? Blood vessels, scar. But only problem है इसमें तुम्हें depth नहीं पता चलेगा कहाँ पे lesion है ना? These are all example of diffuse illumination. Focal फोकल में क्या द पॉइंट ऑफ इंटरेस्ट जहां पे है, जहां तुम्हें देखना है एग्जैक्टली वहीं पे लाइन डाल यूजिंग ए स्लिट। ठीक है, तो अगर मुझे कॉर्निया देखना है तो मैं सीधा कॉर्निया पे डालूं। ठीक है, यू कैन सी जो पहले पिक्चर में इसमें मुझे पता नहीं चल रहा था कि डेप्थ क्या है। आई कुड सी कि देयर आर सम ओपेसिटी बट हियर आई कैन से yes the opacity are at epithelial level here. Here I can say कि see there is a scar in the deeper net. है ना? So this focal or optical section allows you to know the depth of the lesion. Diffuse illumination and focal examination. Focal में ये slit है तो इसमें और एक एग्जामिनेशन जो तुम्हें पता होना चाहिए that is indirect illumination. Number 3 diffuse illumination, focal illumination and indirect illumination. Diffuse में सीधा entire eye together. Focal में focus the light on the area of interest. Indirect में focus the light to an area which is adjacent to the area of interest. ठीक है, फॉर एग्जाम्पल मुझे अगर ये स्कार देखना है, यहाँ पे ये स्कार है तो मैं उसको जस्ट एडजेसेंट फोकस करूंगा। यहाँ पे देखो यू सी फ्यू फाइन वेवी लाइंस, these are ghost vessels। अगर तुम इल्यूमिनेशन यहाँ डाल के ये वेसल देखो, my focal my beam is adjacent to the area of interest। ये तीन एग्जामिनेशन तुम प्रैक्टिस करो, बाकी रेट्रो वगैरह इज नॉट रिक्वायर्ड फॉर यू पीपल, बस टर्म याद रखो। बट फर्स्ट यू प्रैक्टिस दिस 3, तुम्हें एटलीस्ट इतना आएगा तो तुम अपना कैजुअलिटी मैनेज कर लोगे। हैंडल सिस्टम एक होता है, यू कैन यूज दैट अगर तुम्हारे पास है तो। तुम्हें पेरिफेरी जाना है, कैंप में जाना है, इस हिसाब से कोविड अगर फिर से कोविड आता है तो दैट इज नॉट अ शील्ड, यू कैन यूज ए एक्सरे शील्ड। दिख रहा है यहाँ पे, दिस इज द एक्सरे फिल्म दैट वी डिड फॉर द कोविड, बीच में कट करके ये पूरा शीट किया, दैट इज अ प्रिकॉशन यू कैन टेक। बाकी बट ऑल थिंग्स कैन अटर, दीज आर फॉर ऑप्थेल्मोलॉजिस्ट पर्पस है ना। this is what is this? This is a video slit lamp है ना। You can whatever the examiner is seeing here, that is seen here, it will be good for teaching purpose. This is the applanation tonometry for intraocular pressure management that any specialist should do। If you student do this, it's a gonioscopy angle देखने के लिए। इसके fundus examination 90D में। अभी जो मैं जितना मैं बेसिक बताया प्रैक्टिस ले सकते हो। अगर तुम्हें कुछ डाउट है or you become comfortable with whatever technique that I have just told, then you can learn some advanced technique and I will tell you how to do it। ठीक है, but for that क्या time होगा? चलो ठीक है, I'll have another class there। I think we should complete here। कौन सा कार्य करा? You do copy my PPT here। It's in pen drive only ना?